Hello, my name is Sadie Morway. I am a doctorate in athletic training student at Indiana State University. And today I'm going to go through a presentation on my clinical evaluation of the lower extremity. So this is looking at foot, ankle, and lower leg, just kind of running through the process of what I do start to finish to hone in on why I do things the way I do, and then kind of point out some potential gaps in that process. So we're going to just start off with what happened. So this is really the first opportunity you're getting with the patient. And for me, this is a great chance to really create a nice environment for them, knowing that they're safe, creating a calm, stable environment following a potentially traumatic injury is really, really crucial. So then we go kind of right into a mechanism. I feel like this is the first step in understanding the injury and what happened. So this is your first chance to rule out anything emergent. Obviously, you're going to handle the situation a bit differently. But if we're just talking about an evaluation, you're ruling out anything emergent right out of the gates, learning that mechanism and really connecting with the patient initially. In this time frame, we're also talking just a lot of conversation. We're talking about what played into this injury, what they do in their free time, what they do maybe within their activity, whether it's a sport or just activities they do kind of on the daily. This is a good chance to read the patient and read kind of how they're feeling about everything. And really understand their roles and responsibilities within their life. Previous history plays into this extensively, so we take a lot of time. I take a lot of time talking about their previous history, whether that's injury related or just what kind of getting a good idea of who the patient is, kind of putting all those pieces together. The next step is talking about goals. So really figuring out what the patient wants to achieve despite the injury kind of at hand. How does this affect the bigger picture? Why we do all this? This is your connection point. This is kind of creating that bond with the patient, taking the time to really assess their needs and in now, and past, and in the future. I love this. It stresses the importance that this injury is momentary. It's not necessarily monumental. Some gaps here. I naturally don't ask a lot of questions about the support system, which is huge. Additionally, allergies and outside factors, I didn't ask a ton of questions about that. So solutions for that are really asking questions that target those specific things to get a better full picture. This includes any means of assistance, transportation, that kind of thing, any support they need mentally, physically, emotionally, etc. So the next step would then be look, listen, feel. So this is really then getting kind of hands-on, kind of combining that first step with the second, but getting a little bit more in-depth here. So observation comes in, and you kind of already did part of this, hopefully, looking at their gait, how they're presenting, nonverbals, how they're feeling about everything. Then kind of palpating, so poking around, seeing what you can find. And here there's a big trust that needs to be built with touch too. So I usually start away from the injury. I usually, start with just gentle hands and really getting them comfortable with your touch, and knowing that they're uncomfortable with whatever's going on. So hopefully you can slowly work into that. And again, this is kind of your ruling out any immediate referrals. So blaring signs and symptoms of something wrong, this is where you're kind of figuring that out. This is where you start to kind of maybe do some general bony tests, vascular involvement, nervous involvement, really ruling the big things out right away. Then after we poke around a little bit more and get a little bit more hands-on feel, we can start ruling in things. So this is where the differential diagnosis starts. So kind of muscle tone, response. You can work with ranges of motion, active, passive, resistive. Can they move around? Measurement as needed here, so goniometry or anything in that sense. I like to play around with joint movement. So figuring out, aside from just, range of motion of the ankle or foot, how are those bones feeling through the mets? How are the toes feeling? How is the knee working? All of that. So then we go into testing, selective tissue testing. So making sure soft tissue structures are intact and looking healthy in that sense. So Achilles, peroneals, that kind of thing. Then we can go into joint special testing. So, your anterior drawers, talar tilts. Manual muscle testing can also be a part of this. I kind of stick this at the end here because they've been a little bit more comfortable with you at that time. So you're kind of solidifying that differential diagnosis. Why? This is so important, getting a hands-on feel for the patient, the situation, what's going on, building that trust, figuring out your differential diagnosis, and figuring out if everything is working okay. Gaps here, definitely lacking explanation through the evaluation. Often I get hands-on and don't really go into detail to the patient of what's happening. So solution, we can build that trust a little bit and explain steps as I go through. The next thing would be diagnosis and prognosis. So this is really just wrapping up the evaluation and helping the patient understand what's happening. So figuring out your best diagnosis based on all the things you've seen so far, all the pieces of the puzzle, and communicating this with the patient. Prognosis then is, what does it mean? How does this affect the patient? What does this outcome look like for them? How will all of this fit into their plan of care? Then we go on to plan of care. So talking about any referrals as needed, talking about plan of care in the next 24 hours, 48 hours, usually 3 days or a week out or more, answering any questions at that time. Patient education is huge in this step. So really instructing them on things to do to manage their pain, maybe decrease swelling if needed, really figure out how they can do stuff at home to manage this, because ultimately they're only in your care for a short time. And so they need to be educated on what to do when they're out of your care so that they can get better as quickly as possible. Again, answering any questions at this time. Why do we do this? This is the final step. This is the answer they're looking for, kind of why they came to you. They want to know what's going on and what does it mean for me. So really getting into detail about that and how that affects them, and answer any questions there. Gaps here, definitely patient-informed decision-making. Often we know the best thing for the patient and don't really give them the options. So I think I can do a better job of laying out, these are the things we could do, XYZ, here's the risks and rewards for each one, giving them the option to decide their plan of care, if that includes referral or not, if that includes home program or not. So I think solution for this is just continue that education and really giving them options on the table of what they can do to make things better the best they can and what they want to do with it. The last step is really just working together, deciding if you want to continue the care with each other. So this includes kind of planned follow-up. So giving the opportunity to reconnect, setting a timeline, short and long term, setting goals, figuring out what the patient wants to do with their plan of care, answer any final questions. This is important because it's the final steps in care for the patient. So it allows that bridge to kind of be connected in terms of what you know as a clinician and what they're feeling as a patient, really bringing those two things together for the greater purpose of getting better from their injury or illness. Gaps here, I think this can be a lot of information overwhelm. So making sure someone else is present, or perhaps making this interaction shorter and following up sooner in the 24 hours maybe can help prevent some of that overwhelm. Additionally, I don't really ask a lot of questions about fears or anxieties in the short or long term. Usually just try to gauge that based on feel, but that's not always a good way to do it. They need, I think, an objective. Do you have fears about this? What are some anxieties that are kind of popping in your head? Those are great questions to ask. Again, the pop quiz, I think, is a great solution for this, to make sure that they understand all the directions that you've given, and potentially decreasing that first visit in time and information and going on to a second, maybe the next day. So this is my process for evaluation for the lower extremity. Thank you.